Sure. Yeah, I can
Okay.
present a case, no problem.
Okay.
So basically, this gentleman is a 30-year-old male who came to me with new onset seizures and right hemiparesis. He has no other comorbidities. The right hemiparesis improved after we started the dexamethasone. And then we did a MRI of the brain. The video is in the next slide. Yeah. So Asan, you can play.
Yeah.
Yeah. So one is T1 without contrast and one is T1 with contrast. So as you can see that there is a quite a large left frontal solid / cystic lesion, and it also goes slightly on the right side. Of course, there is mass effect as midline shift from left to right. Most of the solid tumor I felt was medially, and posteriorly, mostly it was a cystic structure. So we decided to resect it and did a modified unicoronal incision so that we can also reach towards the right side and remove the tumor. And if you can see the post-op images.
Yeah, Dr. Anila, we do have neuroradiologists also. Dr.
Oh,
Shayan.
okay, sure.
Yes.
Sorry,
Dr.
this is my
Shayan.
first time.
No,
I'm
it's
so sorry
perfect.
about it.
No, it's good to have your also point of view, and then we can ask the neuroradiologist. Dr. Shayan, you want to add something?
Yes, can you scroll the post-contrast images? T1 post-contrast.
Yeah.
Yeah, so you just stop here.
Okay. Let me know where to stop.
Yeah, here. So here what we see a very well demarcated solid cystic lesion, and it has some enhancing component as well, some septations. And though we do not have our T2 and flare sequence in this to comment on the vasogenic edema, but to me, it's basically causing displacement of the corpus callosum and the ventricles. So, and based on the T1 signal intensity unenhanced, it appears to be a low-grade tumor rather than a high-grade tumor.
Okay. Thank you. Dr. Shumaila, do you want to add something?
Ji, Assalamu alaikum. No, I don't think so. I don't want to add anything. I agree with both of the opinions.
Okay.
Yes, T2 and flare would have added more information and diffusion as well, but on the basis of plain and post contrast, even it goes in favor of low to intermediate grade glioma.
Okay. So here we have the post-op T1 and post-op T1 contrast. Dr. Neela, you want to say, what was your feeling peroperatively? You felt like you took it all?
Yeah, I felt I took it all, and it felt like a low-grade tumor to me. Okay. And I think what you see is mostly, I think, some surgical cavity and some blood in it. But of course, the radiologist can comment better.
Right.
Yes, agreed. What we see is that there's a larger section cavity with air fluid level, and there's intrinsic hyperintensity on plain T1 indicative of blood products. So it's, I think, gross total resection.
Okay, thank you. Dr. Shumaila?
Yes, I agree. Yeah.
Perfect.
Nothing much to add, yeah.
Okay. Dr. Neela, just for my own, I would say, it's a question. You did in GA, right?
I did what? I'm sorry?
You did in general anesthesia, right? The case?
Correct. Now, are you guys doing these cases now awake?
Yeah, we try to do awake as much as we can if the tumor is intraxial. And for example, in this case, it was the dominant side. So we would have opted for awake. But, sometimes it depends on the patient also, how cooperative the patient is and all. But yes, we would prefer awake.
So basically, for this case, the two reasons that I chose not to do awake was that I didn't feel that it was reaching, because the posterior cavity was mostly cystic and it wasn't a solid cavity. So, and then it was still not reaching up to the motor cortex. It was
Right.
still very much premotor area. Um, and then I think for the supplementary motor and the mesial area, just to, people can get SMA syndrome, I just felt that it was all pushed on the other side, and mostly the mesial side was tumor. That was one reason. And second reason was that it was reaching up to the ventricle. And sometimes when you
Yeah.
remove these walls, because the most important thing is that if you even remove the cyst, you have to remove the wall. If you don't remove the wall, then the tumor never collapses. So, the worry was that if the ventricle opens, then a lot of time patient can get vomiting and nausea with the ventricle open. So those were the two reasons. I just didn't
Right.
felt the need of doing the awake,
Right.
though I do awake all the time in Multan.
Okay. Great. Great. And you also go for tractography or something like this when you are planning?
Correct. Yes, we do have the facility of tractography. So yes, I always do a tractography before if I'm doing an awake craniotomy.
So you can see the patient was doing well, no deficits, right?
Yeah, no deficits. And then this is the pathology.
Okay. So it says the glioma WHO grade 2, and so Dr. Nila, the pathology mentioned the astrocyte, whether it's astrocytoma or oligo.
Yeah, it did not. See, that was the big question.
Okay.
Now, this is a pathology. It just says diffuse glioma WHO grade 2. It didn't say whether it's an astrocytic. Usually, I always feel that when you say diffuse glioma, it is astrocytic in origin, but I could be wrong. And the other thing is the patient is extremely poor. This whole case was done as a charity case in Multan. So he is not willing to undergo the genetic testing for 1p19q or IDH1 and 2. So in this condition, when the tumor is completely resected, my question to the board is, should I just leave it the way it is and just continue doing surveillance MRI, or should I go for the adjuvant therapy?
And Dr. Mazhar, this question is for you.
Yeah, it's the report is grade 2 glioma. The size was big. Like ideally, in this case, luckily the surgeon got it out completely, as far as we could see, and there is no residual tumor. But we are not sure if there is microscopic disease left, because it's very hard to know, because we. So in this case, patient is young. I think both we can either follow this patient very closely with follow-up MRIs, or if one feels that the patient can be lost for follow-up or is not compliant, then I think one can offer local radiation just to avoid the recurrence. But again, it's one can do both things. Either follow, as I've said, if he can come up for follow-ups, he can be follow-up, and if you feel that he will be lost to follow-up, he's a young chap, you don't want to lose him for the recurrence or something, so one then cannot offer radiation. That would be my safe play in this case. I don't know what the other radiation oncologists would think.
Right. And Dr. Mazhar, you say that, yes, Dr. Neela, please.
The problem is that, in Pakistan, especially in places like Multan, they all come from far off flung villages, right? So, I mean, for me to, no matter how hard I try, I have lost a lot of my patients on follow-up. Sometimes their numbers don't work, even if we try to call them.
Yeah.
But the other problem is that, since it looks like a complete resection to me, I'm also quite wary of sending him for radiation too.
Yeah.
And then since there's no genetic testing, I'm not sure if chemotherapy should be given or not given. So this is all these three questions in my head, what to do.
Yeah. I think you can talk to the patient and see if he can come for at least 1 or 2 years for follow-up, 6 monthly MRI or something, then that would be fine. Because God forbid, if it recurs, one can reoperate on him and remove it. But if he doesn't recur in a year or 2 years, then I think he will be saved of radiation and chemotherapy.
But do they grow so quickly in like 1 to 2 years? I actually thought that, low grade takes a lot of time to grow back again, like in
Yeah,
5 to 7 years.
Yeah, normally we would follow this patient for 5 years, but at least if he can come for 2 to 3 years, at least still follow-up MRIs would give an idea. Like if it doesn't come back, the chances of coming back would be less. Even if then he is lost for follow-up, one would be reassured. But I think you have to need to discuss with the patient about his follow-ups and coming for MRI once every 6 months. So if in that case, if he and other care would be just to refer him for radiation. And I think chemo, I would give chemo because it has been completely resected. Radiation would do the job. He would need, like, if radiation is to be given, it will be 54 gray in 30 fraction, 180 centigrade per day, and that shouldn't give him any side effects. It's quite away from most critical organs like brainstem and the optic chiasma. So, yeah, but still, my gut feeling is that here radiation oncologists would have 50% would say radiate the patient, 50% would say follow the patient up.
Dr. Mazhar, do you know of any radiation place which is good and free? Because there are a lot of patients, they are just not willing to pay for it.
Yeah, well, in Shaukat Khanum, the patients, like, they come for radiation and it's given free to the poor patients. He can try to come to the walk-in clinic. If he is accepted in the system, then he will be rediscussed in the Shaukat Khanum Neuro-MDT, and again the radiation oncologists who are treating brain tumors here would do an MDT with the neurophysician, and a decision would be taken to just follow up or just give him radiation. But I feel my other colleague who's doing radiation in Shaukat Khanum, Dr. Sadia Abdullah, who has recently joined Shaukat Khanum from UK, she most probably would recommend a follow-up in this case, because I've seen.
Thank you so much.
I am a little bit more drastic. I treat the patient. I don't leave them. I just fear that second surgery, I am a little bit more aggressive in giving treatment. So I would radiate him, but I think Sadia Abdullah would not, because I've seen her in MDTs. She argue with me, why are you radiating? Just follow up. And so, you can always have, he can always come to our walk-in clinic in Shaukat Khanum. If he's accepted, he will be given radiation free. Otherwise, the other places where radiation is offered free is in Mole, in Lahore, the Atomic Energy Center, and Minar, maybe in Multan. I'm not sure how good the radiation machines are. But
Minar is, I think they have a very old machine.
Yeah.
So I'm a little afraid of sending them to Minar. Otherwise, that's the easiest one.
Yeah. I would not actually send him to an old machine, because cases like this need very conformal radiotherapy. If after all, if we decide to give him radiation, that should not affect his normal brain all around. That should save all his critical organ at risk. And that is a very sort of specialized planning technique should be available in the center where radiation is given. Because in this case, if we are giving radiation, it would be like an extra precautionary, like to prevent recurrence, where the chances are that he might not recur, and it's a low-grade tumor. And giving radiation and harming him from radiation would be a disaster.
Yeah. Thank you so much, Dr. Mazhar. Really appreciate your advice.
Thank you so much. Thank you so much.
Dr. Leela, if I may add, we worked on the guidelines for, brain tumors in LMICs. And this is a very typical example where we do not have funds, even to confirm whether it's an astrocytoma, it's oligo. We are not sure whether the patient will be following up. So thank you for bringing this case. It's also an kind of a perfect example for all of us, how we are dealing with the cases in our everyday practice. And, when you want to give the best treatment possible to your patient, but, there are many other factors that are coming in your way. So I think I agree with Dr. Mazhar's opinion. If we can follow up the patient, grade 2, it's great. We can have 6 months MRI. If you think you might lose the patient, will not come back, then I think it's better if he goes for some radiation.